Okay, everyone can hear me? Testing, testing. Thank you, Tyler. Hello, everybody. Welcome to our panel supporting disabled people post-pandemic. This is the third installment of Ontario Tech University's panel series, jointly hosted by our faculties of health sciences and social science and humanities. This event was put together thanks to the efforts of our university's Institute for Disability and Rehabilitation Research, which is an innovative research hub that investigates issues related to disability and rehabilitation from the perspective of health sciences and social science and humanities. So it's a cross-disciplinary endeavor. The IDRR, the Institute's acronym, is committed to conduct applied research that is relevant to policymakers involved in disability and rehabilitation. My name is Dr. Jen Rinaldi. I will be your moderator today. I feel qualified enough to moderate to the extent that I'm an associate professor in the Faculty of Social Science and Humanities, specifically the Legal Studies program here. And I am affiliated with IDRR. I also produce disability studies scholarship, and I have a personal history of disability diagnosis, so I have some skin in the game. I represent a university that takes up the practice of acknowledging the lands we live and work on. So I'll start with that. Ontario Tech is situated on the lands of the Mississaugas of Scugog Island First Nation. These are lands that are covered by the Williams Treaties and constitute the traditional territory of the Mississaugas, which is a branch of the Greater Anishinaabeg Nation, including the Algonquin, Ojibwe, Odawa, and Potawatomi peoples. A land acknowledgement grounds our work and reminds us that at least those of us joining from Canada are all treaty people who thus share a history that is riddled with land dispossession and its attendant colonial violence. So some business before we begin. This event is being live tweeted and recorded, and the recording could be publicly released pending the approval of our speakers. Audience members should be able to activate closed captioning via a button on your screen. It should say CC. If you don't see it, then it's probably buried within the button that has 3 dots or ellipses. So today we have a series of questions that structure our time. I will provide the questions in turns, then I'll yield the floor to our speakers for discussion. We hope there'll be time for a Q&A with the audience, in which case you are all welcome along the way to write questions in the chat window. I will try to get to as many as we have time for, and I will be sure to read them aloud for our speakers to respond to. We have an impressive list of speakers who cover a wide range of disciplines today, which means we may use very different terminology when referring to disablement. And we have speakers who will grapple with a wide range of disability experience, given that disability can encompass physical, psychiatric, cognitive, and chronic health conditions. I'll offer brief introductions for each expert we have today, and I will go in alphabetical order. First, Dr. Wouter de Groot is someone who works for the Rehabilitation Program of the Department of Non-Communicable Diseases at WHO headquarters in Geneva, Switzerland, where he is dedicated to COVID-19 related activities and strengthening rehabilitation in health information systems. Dr. Tyler Frederick is an associate professor in my own faculty, particularly our criminology program, where his primary focus is community-based research on how young people, including people with psychiatric disabilities, navigate their way through and away from homelessness. Dr. Evelyn Kissy will soon be an assistant professor at the University of Ghana, where she will pursue her interdisciplinary research interests, which intersect with Black critical disability, transnational studies, Black global health, and lifespan studies in education. Dr. Heather Shearer is a research associate at the Institute for Disability and Rehabilitation Research at Ontario Tech, and a postdoctoral fellow at Holland Bloorview Kids Rehabilitation Hospital. Her research focuses on pain experiences in children and youth with cerebral palsy. And last but by no means least, we have Dr. Samantha Walsh, the National Director of the Disabled Women's Network, or DAWN Canada. Her research takes up disability justice and social inclusion. I first want to extend my sincerest gratitude to all of our speakers for joining us today from different corners of the world in some cases, to have this, I think, timely and important discussion. And before I launch into our substantive questions, I did want to yield the floor to you all. Is there anything crucial I missed you'd like to add to your introductions or correct? If we're good, we can proceed. Wonderful. Then here we go. My first question for you is this. Disabled people and people with long-term health conditions, at least in principle, have access to a range of rehabilitative and therapeutic services to improve their physical and mental functioning. And those are services that operate in the context of a healthcare system that has been under considerable strain in these past 2 years of COVID. I think my question is, how have disability and rehabilitation services adjusted to pandemic conditions? And are those conditions or adjustments, are those adjustments irrevocable? Who wants to open up our panel today?
If you want, I can start.
Love that.
Because it may provide a global perspective first. I don't know the Canadian perspective or the situation in Canada, but WHO is conducting pulse surveys with countries, member states, to assess disruption of essential services. And for rehabilitation services, what we have seen, so this is a pulse survey that is conducted at regular intervals, as in every half a year. And last quarter of 2021 has told us that, or the survey at least has told us that 50% of countries globally have their rehabilitation services disrupted. And 12% reported on a more than 50% disruption. So this is how the pandemic has affected services, at least rehabilitation services. In terms of adjustments, we don't know for sure how rehabilitation services have adapted to the context of the pandemic, but we know there's several mitigation strategies used, such as home-based care that has been increased, self-management if possible, redirection to care sites that may be more appropriate, telemedicine, of course. The training of staff, recruitment of staff, psychological support of staff, financial strategies, as in including private sector, using public funds to improve access to essential health services, or removal of user fees. So this is what is globally done in terms of mitigation strategies. What is I thought interesting from the last pulse survey is that the disruption of rehab services compared to Q1 of 2021 did not change. So we have the same disruption of rehab services since kind of the beginning of the pandemic. So that was surprising to me that countries were not able to open up yet. And unfortunately, the data of WHO don't give us an idea about how rehab services in particular have used mitigation strategies. That I cannot tell.
That's a fantastic overview with you're right, transnational focus to show that we've seen not an easy bounce back, that we've seen adjustments that might be carrying into the long term, which means that maybe in our first question, we're calling into question the title of the talk itself, which is that we're not actually in a post-pandemic world just yet, that we're still seeing shocks reverberating through our rehabilitation systems.
Exactly. Yeah.
Fantastic. Dr. Shearer, you're an expert in rehabilitation services as well. Maybe you have some thoughts on this question too?
Yeah, I'd be happy to provide some input, specifically from sort of the pediatric realm, which is regional in Ontario. I have specific experience with 2 children's treatment centers, and these focus primarily on children with neurodevelopmental disabilities. So there's a range of children from autism to cerebral palsy to a variety of other disorders. So what we've seen with these units is they follow the guidance of the Children's Health Coalition. So this is a group of children's pediatric hospitals across Ontario, and other groups that really they really are looking at the safety and mental health of these children. So during the peak times of the pandemic, there were definitely shutdowns of services. So for example, only critical patients were seen, and not necessarily for rehabilitation services. These were more appointments with developmental pediatricians or physiatrists, or critical interventions that needed to be done. So for example, Botox interventions, which happen on a less regular basis. Whereas, kind of core rehab services like speech, occupational therapy, physiotherapy, these were no longer done in person. So these were offered through Zoom calls. They would have phone check-ins with the therapists and the parents and the kids. And for some, this worked actually very well. And for others, and depending on the type of service being provided, it was not ideal. This is, of course, changed now because things have started to open up. And for quite some time now, individuals have been back at the treatment centers having in-person visits with therapists. So we are seeing this kind of quote unquote return to normal. I don't know that we're definitely not there at the treatment centers. So they're still employing screening, masking, and all the public health measures that have been in place for kind of the duration of the pandemic. So because the vulnerable population being served, they are still using these. But we are back to in-person treatment. In terms of recreational therapy programs that are offered, that's a bit of a different situation. And so that's going to have, I think, longer term consequences. And that's something we can get into a bit later. But that's a whole nother piece that's missing.
Thank you so much. Can I throw a curveball and ask a question that's not on the books? Maybe we can cut this out of the recording. But I'm curious, with the shutdown of services, has that been due to a prioritization of healthcare services to meet the needs of like populations that are contracting COVID, or has it been that like public health measures have required a shutdown of services because isolation has been the way to protect people?
So at the treatment centers, so depending on the treatment center you're speaking of, so for example, Grandview Kids doesn't have an inpatient unit, so theirs was really more in line with public health measures, whereas at Holland Bloorview, they have both inpatient and outpatient services. So they continued their inpatient services, and they actually took on children from other hospitals, but their physical rehabilitation was severely reduced or stopped at some points. The in-person portion, they still continue to have Zoom calls, but they did really reinstate it as quickly as possible because they know how vital it is for these kids to have this kind of therapy. That's the one great thing about the treatment centers, is that they're very in touch with how important this is in terms of the children's health and well-being, mental and physical.
Thank you so much for humoring my extra questions.
Sure.
And in the spirit of interdisciplinary collaboration, are there any of our social science and humanities experts who want to weigh in on this question?
I can weigh in on this. I actually would like to say this is an interesting question, Jen. I think speaking from the context of Ghana, we are still in the principal documentation stage, right? We have a couple of disability advocacy group currently working to assess, I should say, the situations and the impact of COVID on folks, particularly in the institutions, communities, and education institutions as well. with little or no funding, this way we can't really speak of post-COVID unless this is done, right? But based on what my colleagues on the ground are seeing in Ghana, our post-COVID for disabled folks brings us back to the beginning when disability is seen as a charity case. So we are still at that stage. And we are in the place where we can't speak of rehabilitation post-COVID, right? Because of that context, or because of where we are right now. And then what I always put into context is Ghana is 65 years, and this is due to colonization and everything. So the answer for me with that question would be no. And are the local ways of rehabilitation being recorded? So we do have different groups that are resistant to biomedical Western way of rehabilitation, but that we have this local different groups, different communities doing rehabilitation, excuse me, that supports their being, that supports their personhood. But do we have a record of those? And that's no, obviously also due to lack of funding that we get. So this is why I say that we are still in that charity disability looked at or seen as a charity case. Let's give this much or this little so that, you know, they feel, or the world sees, that disability is being looked at, and rehabilitation is also being spoken of. But are we there yet? I don't know if we are yet, and I will argue we're not. So we still have quite some work to do when it comes to COVID or post-COVID or whatever we're trying to term it now. Looking at also the outbreak that is coming from the new variants coming from US now. So yeah.
Thank you so much. As a pretty thoroughly locally based scholar, I'm already benefiting. I'm already learning from our transnational scholars on the panel about how to open up these questions, to think about a reframing where our healthcare systems, depending on the context you're looking at, have been under considerable strain, not just because of COVID, but because of underfunding and colonial forces. So that's a really lovely reframing of the question. Is there anyone else who wants to contribute to this question? Dr. Walsh, you might want to unmute.
Sorry, it's the first time I've ever used a computer or technology, really ever. So I really appreciate Dr. Shear's answer, because what my experience has been, and just to give some context to who I am. So I am the newly appointed National Director of DAWN, but that's a fairly new appointment. So today my comments will mostly be from a research context and a lived experience context of having I have CP, which is a nice coincidence with Dr. Shear's research. And additionally, prior to working at DAWN, I had worked in the healthcare and attendant service sector, and I sit on the board for Independent Living Canada. And all of this is to say, on the flip side of that, from a individual perspective, what I've observed is that it's become a really interesting discussion amongst individuals about, like, what is vital rehab, what can I do without, and what am I willing to sort of manage risk about. And then it's really interesting as well, because we've also seen a bit of a resurgence of neoliberalism or a neoliberal approach to rehabilitative services. So folks who are not necessarily comfortable engaging with hospital spaces or typical spaces of rehab, but rather looking to pay someone privately to come into their home, or in some cases with attendant services, pay someone privately to agree to live in their home so that they have the comfort of isolation, which then creates a bit of a tiered model of care, because that's if you can afford that, that's a great strategy. But not everyone is going to be able to manage that. So it's been really interesting to see how it breaks down on a micro level, and how COVID informs this sort of reframing of choice for consumers.
Wonderful. I think I didn't think I understood rehabilitation, but now I have a familiar conditions that I see in my own studies around colonialism and neoliberalism impacting the kind of services we make available to people and how they might be adjusted through the COVID period. Dr. DeGrout.
Yeah, I just wanted to add to this
Wonderful.
discussion. I mean, I think part of your question has been whether these adjustments that we are experiencing are irrevocable. Will they stay? How will the future look like? And there's this hype of the building back better idea. And in terms of rehabilitation, and I have not been working in the field. I mean, I'm a physiatrist, but I'm at WHO for a few years now. So providing technical advice and reading a lot. So I have not been practicing rehab as such during the pandemic. But for what I learn is that we may be more effective in providing rehabilitation because of the pandemic, because tele-rehab, for instance, especially for looking at tele-rehab has been proven to be effective in some cases, as Dr. Scheer just mentioned as well, for some particular cases that might be well selected. And we have globally this issue of access to rehabilitation services. Ghana is of course one of these countries which has only one physiatrist, Ghana. So I'm kind of promoting for the scientific community to build evidence for tele-rehab, for us to be resilient in the future in terms of responsiveness and increasing access to rehabilitation services. We may in the future be working with more hybrid approaches of models of care than we have done before. And user satisfaction may be higher. And when and if so, we will be more resilient for future waves and pandemics.
Wonderful. So there's something to the possibility that the pandemic has forced us to reimagine access to services. And that might be creating more creative solutions to serving disabled communities. Dr. Scheer, you might be closing us off, if no one minds my wrangling the discussion.
Sure, I'll just add one quick point. I think that's an excellent segue in terms of a hybrid model, because we're seeing that, and research is coming out certainly from the children's treatment areas, from CHEO, which is the hospital in Eastern Ontario, Grandview, and Holland Bloorview, where they're proposing research to look at who best suits these kind of hybrid models of telehealth, rehab, and so forth. So I think that is a good step forward for delivery of care in this population, and several rehab populations, actually.
Wonderful. And then I was wrong, because Dr. Kissy is going to close us off.
Sorry, Jen, just a quick, I think the telehealth rehab, that my colleague spoke about, I think it's an amazing idea that would work when we talk about the urban city of Ghana. But when we talk about the rural area, I remember I was there a couple of months ago, and I went all the way to the northern region of Ghana, and I had a meeting over Zoom, and my internet totally cut off because access to internet, was, so, and with this research I was doing was more of access to education. So to me, I'm like, okay, so how do we talk about access to education if I'm at this junction of talking about education on Zoom, and I can't get my voice across the panel just to even talk about what the issues are. So I think telehealth will definitely benefit, but I think when we talk about the rural areas of some of the localities in the global South, it's still something that we need to understand and figure out how to mitigate the access issue when it comes to internet and all these different things. And secondly, also when we talk about telehealth, and we are talking, and we're bringing in practitioners from outside of the continent. How do we start to talk about the cultural relevancy, and then looking at rehabilitation from the cultural perspective? How do we contextualize that? Who is monitoring and evaluating that we're not creating harm as well, right? So those are some of the things that started to creep in as we start talking about this hybrid model of rehabilitation. But I agree, it's an amazing idea, because even in Accra itself, we're still lacking rehabilitation, and Accra is very accessible when it comes to internet. So how can we start those conversations within the urban space, but then look at how do we mitigate it across the rural areas of the global South?
Thank you so much for that contribution. So it sounds like there's all these compounding factors when we imagine access. So as we're trying to create rehabilitation services, we have a range of conditions to consider that are maybe culturally and geographically and economically specific. I'm so thrilled that the first question went so well. Felt like an energetic back and forth. If no one minds, I might move on to number 2. And maybe as a housekeeping note, if no one minds, I might shift to first name basis. It does feel more comfortable whenever Evelyn uses my name. It sounds like people don't mind because I see smiles. Okay. Tyler, then, I want to bring you in as an expert on the next question. Maybe you can lead the discussion, and I'll read it accordingly. Disablement coupled with inaccessibility and impoverishment already complicated housing security in pre-pandemic times. So the question is, how has COVID-19 impacted the services that make independent living possible and the services that shelter unhoused disabled populations? A follow-up, how should those services be structured going forward?
Thanks, Jen. That's a really good conversation. I feel like there's a lot, and I'm not sure I'm going to sort of tackle it exactly correctly, but I mean, my research area and sort of where my mind goes is primarily around folks who are experiencing episodic homelessness or chronic homelessness. And so, I mean, right off the bat, I think we sort of saw, at least here in Toronto and in Canada more generally, seeing, with the pandemic, seeing a lot of sort of the risks and challenges that come with congregate living settings and all the kind of, and that could be, an emergency shelter, or it could be kind of a group home setting. And then I feel like another sort of thing that sort of really came out of it, and other people touched on it regarding the rehabilitation piece, is just, and one thing I think that I've been hearing more clearly is this issue of staff burnout. So a lot of my community partners are folks who offer transitional services. So this would be for young people who are transitioning from homelessness to housing, and so are in supported housing of some sort, or in some sort of housing first program. And there was a ton of staff burnout and a lot of staff turnover and challenges there. And so, it'd be, one of the things that comes up is, for the kind of the young people that I work with most, they're really often quite isolated and pretty limited supports. And so this sort of staff turnover, this sort of, insecurity that comes with not knowing who your worker is and things like that, I think can be really, really kind of challenging. Then sort of, I don't know if this is kind of taking it too far off to the side and kind of dragging this whole conversation towards housing and homelessness issues, but one of the things that comes to mind for me is that, there's these direct effects of COVID, but obviously right now in the Canadian context, we're seeing these kind of spin-off consequences and issues around kind of just general price inflation for so many things, as well as just an outrageous housing situation and an outrageous housing market. And so, that's kind of where my mind goes in terms of the threats to people's housing stability, both in terms of just basic access, right? If you happen to be looking, it's extremely hard to find it. But then one of the kind of other parts of it I find, and with the folks that, that we work with, many of who have sort of various, thinking really broadly about disability, whether it's psychiatric or learning, cognitive, brain injuries, these kinds of things, is the fact that folks, when the housing market gets so tight because of COVID and other related factors, these folks are pushed to the sort of very kind of bottom end of the housing market. And then there's all sorts of problems and shenanigans sort of at that bottom end, right? The, pests and bed bugs and safety concerns if you're living in a boarding facility or sort of a boarding room, kind of shady or kind of dodgy landlord practices. Right now in the news here, there's a lot of conversations about evictions and rent evictions. And I think kind of folks with disabilities and other kind of marginalized people are really vulnerable to those kinds of practices because, navigating the landlord tenant board as sort of for the, for anybody at the best of times is really, really difficult. And so for folks that might have some additional challenges, and I know, landlord tenant and various groups don't do a very good job of accommodating people with disabilities, generally speaking. And so, just a lot of layers there. So yeah, hopefully I'm not taking it too far away, but my mind kind of goes to some of the push and the crush for people around housing in particular.
No, I think that's perfect. This idea of push and crush, where disabled populations are being pushed into unsafe housing conditions and congregate living conditions, which are going to increase their risk of exposure to mass infection, alongside all the other sorts of risks that come with living precariously.
Just to add to that, I mean, we saw too, there was a lot of tensions here around this. How do you respond to that on a policy level, right? And so, a lot of the cities did a kind of relax some encampment rules really kind of temporarily, but then those came back in kind of full force. And the idea was, listen, the shelters are safe, just go there. But people really didn't feel comfortable with that. And I feel like there were some missed opportunities to kind of figure out some new ways of supporting people in encampment settings where they might actually feel safer. But yeah, sorry, I'm kind of monopolizing. I'd love to hear if there's other thoughts.
Very happy to have you monopolize. Glad to have you in the conversation, Tyler. And I am reminded of all those encampment evictions, particularly in Toronto and the near Ontario area, where people living rough and unhoused populations were targeted through a pandemic where housing was not secure. Thank you so much for leading the way in this discussion. Does anyone else want to weigh in?
The points around Tyler's points around service navigation and just a general lack of housing are really astute. Folks with disabilities in general are often made to do extra work to legitimize their conditions and legitimize their needs for those accommodations. And we see it becoming intensified during COVID. So service navigation is such a huge piece, and it's so difficult, especially when navigating a pandemic. If you've already got some issues with organization or just general fatigue of being tired of telling your story over and over. And again, crisis highlights a need for more affordable, accessible housing.
Thanks so much, Sam. I even have some memory of your work in the service sector, supporting people finding accessible housing, and how the wait lists are so long, and how it's hard to find secure housing where people don't barge in on tenants.
And then a direct impact of COVID is folks are no longer interested in living in group settings. So then there becomes a push towards, I want to find a self-contained unit that's retrofitted. I want to change my support systems. I want to move towards investigate things like direct funding. And it's direct funding is a fantastic program, but there's a waiting list and there's steps that have to be taken. So a crisis builds more panic.
Wonderful. And it sounds like, I mean, even in efforts to rehabilitate people so they're able to like enter into and participate in community, that they still encounter all these barriers around like safe, secure, independent living.
Yes.
Thank you so much, both. Anyone else?
I was just going to sort of jump on what Dr. Walsh was saying there. That was all that's really great comments. And like, it makes me think of some work we've done for just in what you were saying, Jen, about kind of this isolation piece and this, we've done some work on sort of folks with, mental health disabilities or psychiatric disabilities, however you want to classify it. And this sort of, this idea of sort of you get folks into the community, but then, because of poverty and discrimination and all sorts of issues, they're really isolated to start with. And it can be really hard to find community and find connection and things like this. And so then you kind of layer in COVID and, the anxiety that comes with that and the, this kind of everyone generally speaking, retreating home. It just would kind of exacerbate all of that.
Wonderful back and forth. Thank you, Tyler. Anyone else want to weigh in on this question? I actually think we're back on track in terms of timing. But I do love to watch a clock. If we're comfortable moving on to number 3. Okay, great. So I made this one long-winded. My apologies. Here we go. So provincial governments in Canada, at least, have been in the process lately of dropping mask mandates and passport systems and pandemic-related restrictions. And they're doing so aligns with government actions in several countries around the world, although I might want to check notes with our transnational scholars on where pandemic restrictions sit, whether they exist and whether they're dismantled. This could spell disaster, though, the absence of public health conditions for disabled people and people with long-term health conditions who have COVID-related vulnerabilities, either due to biological or social factors. So I'm thinking about my immunocompromised mother, or piggybacking on our last discussion, I'm thinking about like my grandmother having to live in congregate living settings. So what are your thoughts on ending these public health protocols? Are there lessons to learn from the work in disability studies and rehabilitative research fields about what normal can look like as governments are calling for a return to normal living or are resisting making adjustments to what conditions look like on the ground? Evelyn, you want to start us off?
Yes, I think this is a great question, Jen. Unfortunately, our case in Ghana is totally different from the global north. Masking in Ghana is a luxury, right? And not for the vulnerable disabled folks. This is unfortunate, but it is due to affordability of acquiring masks. And also we see that the community also see COVID as the disease of the elite, right? So there's this rhetoric going on that, is it or is it not? I think that's a question that research needs to tell us. How do we now compile this conversation of community understanding of impact of research, impact of COVID, and do we see more elite classes impact than community spread? Right? I think that would be an interesting research to take on. Secondly, many have related COVID also to malaria. I don't know if, I'm sure we all have heard of malaria in most of the global southern country, leaving them to resort to taking more of the over-the-counter malaria drugs or more natural form of traditional healing rather than the biological, biomedical medicine from the West, which they argue works better actually than the Western form of medicine. Again, another form of resistance or Maybe, is it working? Is it not? Do we need more education and understanding and countering COVID within Ghana? Maybe, maybe not. Well, but in Ghana, I can also say, and I argue also, even in some of the communities in the global north, testing is also a luxury for us, for folks in Ghana. Will this lifted restriction affect the vulnerable folks in Ghana? Definitely, because we see more folks from the global north visiting and also going back home to Ghana to see their families, their vulnerable grandmothers, their vulnerable moms. So I think this is our government organization and international organizations sitting on the edge of their chair, thinking what would happen, or are we going to see an increase with travelers coming into the country? I think this is something that they need to start to monitor in terms of the restriction that has been lifted. Are there lessons to be learned from the work of disability studies and rehabilitation? Lessons to be learned from the work of disability studies and rehabilitation research field here in Ghana? Definitely, but I will add that we are in need, Ghana definitely is in need of research funding to do such research so that we're not projecting the global normal onto the global southern nations. Specifically in Ghana, the post-COVID in reality does not exist, as I mentioned already. But should it exist? Hell yes. Sorry for my language, but yes, it should exist for, I think, every vulnerable community, even for those of us who are not, or for those folks who are not in the classification of disability, post-COVID still exists, right, for everyone. So why not persons who are living precariously with lack of housing that is accessible to them, right? So how can we talk about post-COVID around this community, around this group living precariously in slums or outside in homelessness and all these different things? So we need more research on critical disability studies, definitely, that contextualizes the realities of the communities here in Ghana or in Ghana. From a lifespan perspective, right? This is the unfortunate issue that researchers and advocates face. And at the end of the day, they result in to speaking about the new normal as per the prescription of the West, right? So this becomes disabling to folks living the realities of disability in Ghana. And so we are basically right now that there is a lift of COVID restriction because the West has already lifted COVID restrictions. How do we mitigate increase of COVID cases, increase of this disabled folks seeing more COVID impact and all this? So there are this complex conversations that are not happening. And what would that look like, as we say, post-COVID? Is there really a post-COVID? And that's the question I'm still asking for my disabled folks in Ghana. For them, is there really post-COVID? So.
What a fantastic range of complications if we see pandemic restrictions lift in other areas of the world that reverberates because we're talking about a pandemic, and a lot of these restriction lifting measure, like the effort to lift restrictions is tied often to vaccine rates, but we have like mass vaccine inequity. That means that we can only really see pockets of a post-pandemic world if there are people with enough resources to stay isolated until COVID variants reach them. They're able to to thrive in spaces where inequity reaches. Walsh, my apologies, your hand is up, and I was rambling.
Exactly, Jen. Sorry, and I think you bring a very important point where, you know, half of the population is not vaccinated as well. So how do we unpack those hierarchies of compounded issues that, you know, will create a more vulnerable space for this population, right? So
You
I don't
articulated
know.
it better than my rambling. Perfect. Walsh is next, I believe.
Yeah, I found that idea about the COVID-19 being a disease for the elite very interesting, because who is most at risk of getting severely ill from COVID? Increased age, male, and underlying health conditions. So these are probably common to people that are wealthier, live longer, have diabetes, chronic lung diseases. So not sure if you need another study to look at whether this is true. I believe this fits the profile of the elite in an African setting. Today, WHO launched the third strategy on how to prepare and respond to the pandemic, and hopefully the last. And so the most likely scenario is that we will have a virus that continues to evolve, but will create less severe illness in people because of vaccination status in a country and immunity. So this being said, I believe, so when talking about returning to the normal, countries need to revive in terms of economic economic situation. So there's a difficult balance between removing restrictions that enable economic activities and whereas protecting health of people. So that balance is a difficult balance. Mm-hmm. So my argument would be in terms of lifting restrictions, yes, that's what the community needs, what the society needs. Even for all of us to be able to access basic goods, we do need all activities to be fully active, I believe. On the other hand, people that are vulnerable to the COVID-19, and I mean, are those disabled people? Yes, they're more proportionally, they're more disabled people that are severely ill. That is correct. And still anybody can become severely ill, even though if no underlying health condition. 80% of children in intensive care have no underlying health condition. But protecting these people with vaccination and boosters and have these ready for people that are vulnerable for severe COVID-19, in my opinion, that is not a WHO opinion. That's my opinion. Would be the best approach.
That's and it sounds like you have we need to tie COVID restrictions to vaccine equity, that vulnerable populations need access to vaccines and boosters so that we're able to restart economic relations, economic productivity.
Yeah, correct.
Thank you so much. And then Heather is next.
I think this has been so enlightening to hear the different perspectives. One thing that I'll just chime in terms of the pediatric perspective, because so many young children, especially young children with disabilities, aren't eligible for vaccinations yet, or many of them haven't sought them out. So I think in terms of restrictions, and this is, again, my opinion, I think I'm glad things are opening back up, but I think it's important to maintain at least masking restrictions, at least in schools, because they're in such close settings, certainly in Ontario, and I'm sure around the world. Many of the classrooms don't have proper ventilation systems. You're not opening windows in the middle of winter, so forth. So, you know, there's that increased potential to have viral spread. So for me, I think masking is still a very important public health measure to continue, at least for the short term or the foreseeable future, and in specific settings. So at least at schools. one thing that I want to touch on in terms of kind of the normal that we're going to return to, not a lot of people talk about positive outcomes from COVID. And one thing that I want to touch on is for people with disabilities and in work environments, what we've seen is that, you know, people are able to work remotely very successfully, very productively. And in the past, people with disabilities have really been, and I've heard about this from friends of mine who are, you know, young adults who have disabilities, specifically cerebral palsy, and they're almost shunned from workplaces because they're not able to work remotely, or there's very limited access to work remotely. Well, now, you know, the proof is in the pudding. We can do this very easily, and we can accommodate people in the future. So I would like to see kind of the new normal as being people with disabilities and people who need accommodations for whatever the reason being, that in terms of work access, they are able to have either a hybrid model or a completely remote work model. And that will help a huge segment of the population, I think, in terms of a normal outcome from COVID.
Those are some lovely nuanced points about what the new normal might need to look like, where masking in specific spaces can protect vulnerable populations, and people can be rendered vulnerable through disablement and age, as you note, but also that we've created new ways of engaging in work that we shouldn't just drop because public health restrictions are ending. Given that this could be a real boon for people who have access needs. Wonderful, thank you so much, Heather. Any other takers on this question?
I just one thought. I don't sort of bring any sort of special expertise here, but your question was interesting and it got me thinking about, I mean, and I think I might be really speaking for kind of global North Canadian context here, but this sort of issue right now where, you know, more people are wanting to take off their masks and other people with, you know, who might be immunocompromised are kind of concerned about that, and how is that going to affect their ability to be out in the world. And then sort of gets you thinking about, as we kind of move into this more sort of, you know, quote unquote sustainable kind of world, or, you know, version of our kind of public health policy, I'm curious like how public health messaging might be able to evolve around some of these policies. And I'm thinking kind of specifically of masking, in the context of masking, maybe being, you can kind of see it through the lens of a universal design kind of idea, that masking in some settings going forward is sort of could be really beneficial to everybody, not just folks who are immunocompromised, right? Like, you know, going forward, when I go to the mall, for example, to use a privileged example, if I go to the mall, you know, during the cold and flu season, there's a good chance I'm going to want to wear a mask. So it just makes me think right now the context is kind of difficult, because I think the way kind of, you know, a lot of the masking discourse and debate around it is it's sort of this like off on, right? Sort of the pandemic is happening or it's not happening, or you're kind of pro mask or you're anti-mask. And I think it makes it difficult to kind of find that middle ground where someone can sort of feel comfortable having their mask at some point, but not other points, and kind of moving to something that yeah, is more kind of nuanced and more sustainable. And so I have no sort of real answer there, but I just kind of, your question kind of rang that bell for me.
I like this suggestion to our audience that maybe we can wear masks forever, because I will. I love my mask so much. So, and there is something to, I imagine that people working in rehabilitative and therapeutic and medical services will have to continue masking because of their close proximity and when supporting disabled populations and people with health conditions. I think people working in long-term and congregate living settings will have to continue masking to protect the populations that they serve. So even if we can change the status of COVID from pandemic to endemic, which Evelyn is right to say is something we can contest itself. But even if we could get there, maybe masking is not something we're giving up all wholesale. Wonderful.
Sorry, just to add to Tyler's thoughts or thinking through of masking. I think that would really having everyone wear masks will also help to eliminate the discrimination or the stigma that those persons with disability who are immunocompromised would face if they decide to wear a mask. And then it also eliminates this anti-vaxxer or this different things. But then for me, what I started thinking of when you were talking, Tyler, is also it reduces, or will it reduce this commodification of bodies, right? Because if you're not seeing, I don't know. I think that conversation can be straightened up a bit more, and then it's a discussion to have. But yeah, I like that thought, Tyler.
Seeing agreement across the group. That's great. Samantha might have a hand up because she has a burning contribution to make.
Is it okay? Is there time, or do you need to move on?
There is time. I'm not supposed to be managing the discussion quite in such a stranglehold anyway. So, but you get to decide whether there's time actually as experts.
Okay, fantastic. So I just wanted to say quickly 2 points. Heather, I too am excited about remote work, and I think it opens up all kinds of spaces for folks who are disabled. So great point. And then thinking about what Tyler said, one of the things that the masking debate or discussion harkens for me, and it's interesting because there's a bit of a conversation going on in the chat about how masking affects folks, is it really compels us to think about who we're making space for. So in another way that I've thought about this in my work, or like, and this is a common example within disability studies as well, is that if we're building a building and I were to say, like, there's no men's bathrooms, we ran out of money, there's no space, I couldn't open my building. It would just be pandemonium. Whereas if I were to say, like, oh, we ran out of money, or we don't have space for an accessible bathroom or a single person washroom, there would be complaints, but my business, my building would still open. And so what we need to think about is, like, who are we making space for? Like, who are we making space for in our built environment? Who are we making space for interactionally? And I think too, and this has been touched on a little bit, the idea that like, disability is not a small minority. It's a group that folks can enter in and out of. So recognizing that the space we're building and the interactional opportunity we're making by having some masking conversations really speaks to, like, who we imagine and who we value in our society. And of course, my point is all grounded in Western views and an Ontario-centric view. But it's interesting to see who we imagine being prominent, and who we're excited to interact with.
That might be a great way to cap off. Nope, I'm wrong. Evelyn from the side.
That's a good question. Sorry, I'm just Samantha. One of the marketing that Ghana is using right now is what's it called? They're asking folks, African American and every Black folks outside the diaspora, to come home, right? And one of the questions I've been asking is, who are we asking to come home? Because and who are we making space for? And I like the way you framed it. Who are we making space for? Who are we imagining when we go to the airport to pick up family member, to pick up anyone? Are we actually imagining someone with disability? And when we do we have that space, around to accommodate that person, to make sure that even though if they're immunocompromised, if they have some form of disability, is ready to accommodate them, right? So that question of who are we making space for, I think, can be broadly used in the context of the global health as well. And how do we imagine space? And how do we imagine this person in the context of post-COVID as well? So
I agree. It's a beautiful line. I hope if there is a student live
sorry, Jen.
this talk that they manage to get that line into a live tweet. Don't you dare apologize. I'm thrilled that the conversation has movement and feels organic. So my apologies for always cutting in. But I might still in that spirit move on to number 4. I am eager to ensure that we get to that question in the chat before we close off today at 1:30. So our next question is that political actors have referenced mental health impacts, specifically in relation to isolation, at least in the Canadian context. That might shift with the conversation that comes. But we've seen the reference to mental health impacts as a kind of cudgel to justify dropping pandemic-related restrictions. So I'm wondering how you speakers would characterize the mental health impacts that COVID has had, and what supports you think people with mental health conditions and disability need to manage in and beyond a pandemic.
Quickly, probably important to make a distinction between the mental health impact that results from COVID-19 and the mental health impact that results from the pandemic and / the restrictions, because there's a difference. I believe isolation has been one, anxiety is higher, and even depression seems to be higher in people that have not been affected with the virus. Use of cannabis is higher in students, in Belgium at least. But in terms, and I don't know about the mental health impact resulting from the pandemic. That I don't know. I'm not the expert. But in terms of the mental health impact that results from COVID-19, and there are many people infected with the virus and that have become ill. There's specifically 2 health conditions that result from the COVID-19 or the disease itself, which is the post-intensive care syndrome, and the other is long COVID, or WHO's definition, the post-COVID-19 condition, which has a lot of issues in terms of mental health, post-traumatic stress disorder, anxiety, depression, and in those with the post-COVID-19 condition, we're speaking about up to 1/3 of people. So those that experience persistent symptoms beyond 3 months of the initial disease, and that is about 10 to 20%. So about 10 to 20% of people that got infected with the virus, irrespective of their initial disease severity, may develop long COVID or post-COVID-19 condition. So even you and I, and not only the elite, as been told before, and all of us can experience the post-COVID-19 condition, and out of those, 1/3 has mental health issues. So we do need to do something. That's correct.
That's a really useful and important distinction, which helps me fold in my last question anyway, so our time is saved. COVID sounds like it's itself a kind of mass disabling event if you're speaking to such high numbers of people who are dealing with the symptoms of long COVID that includes mental health disability. And it sounds like we have a lot of work to do to make sure that this is a population that is accommodated.
Yep.
Heather.
I really like that distinction, and it's interesting now that I think about it. I don't actually recall seeing any studies that I've come across, at least, looking at post-COVID symptoms from a mental health aspect in the pediatric population. So I'm going to actually look at that after the call. But in terms of pandemic-related mental health, we certainly see there have been lots of reports and lots of research studies outlining the effects of the pandemic on the mental health of children and youth. So we see increased anxiety, increased depression, resulting from the isolation. I think, you know, the knee-jerk reaction is to say that the pandemic has been terrible in terms of mental health for a large portion of the population, not just disabled individuals, not just children, but really a large group of people, just from the simple isolation and lack of being able to see loved ones. But I think the bigger issue is how underserviced mental health supports, so underfunded, underserviced this sector is right across the board for children, for adults, anybody trying to access mental health services. Certainly in Ontario, I would venture to say across Canada and really in many parts of the world, this is a real issue for people. You know, and I speak from a lived experience as well as what I'm seeing in research. And, you know, when you have children who have suicidal ideation and you have to wait 6 months for a psychiatric consult, and your only option is to go to the emerge department for immediate care, that's a bit worrisome, you know. And then you're forced to turn to private care. So again, we're looking at a privileged group of people who can afford access to private therapy, which costs a good amount of money. That's quite challenging for a large portion of the population. So this is something that we really need to push with government agencies in terms of providing more service and more funding for not only rehab services, because we know that's underfunded as well, but certainly the mental health aspect related to mental health in general, but also related to the pandemic. Because just once we see restrictions end, we're not going to see the mental health issues dissolve. These are going to linger for quite a long time. And I think we're going to see a long-term impact from that as well as from the individuals who've actually suffered from COVID.
Thanks so much, Heather. And Boucher, your hand came up, so maybe you want to respond directly to Heather.
That's an old hand, sorry.
Oh, old hands. But I think Evelyn got kicked out of the call, so her hand doesn't count either. Any other speakers want to bite?
The only thing also to add to it, just from kind of the population that I work with and study, and this is sort of very anecdotal, but I know a lot of emphasis has been put on the isolation as sort of the cause of sort of mental health concerns and anxiety and depression. But you know, from talking with folks, I also get the impression that, you know, especially for people who are kind of marginalized before the pandemic, the problems have been sort of around like a lot of uncertainty, right? You've kind of worked really hard to get to this place. You've put these plans into place to go to school or do this. And then all of a sudden, everything kind of feels up in the air and uncertain. And, you know, do I still want to go to work? Or, you know, I had that job and now I'm kind of scared for my health. And so maybe I won't go to work, or then I'm going to get fired. And then if I get fired, you know what I mean? And so I think, I don't want to say that too much emphasis was put on the isolation piece, because clearly that was hugely impactful for so many folks, including the folks in my world. But, you know, just to kind of draw out that there's other kind of implications too, for sure.
Wonderful. What an interesting take, that isolation might not be the chief cause, the only cause of mental crisis, mental distress. COVID has created all kinds of uncertainties around like security and access needs, and what our scheduling might look like, and the kind of people we might be able to access for services. So uncertainty might be itself its own different kind of cause. Thank you so much. We still lost Evelyn, unfortunately. She might be trying to get back in. And I see her now. Wonderful. Evelyn, I saw your hand up earlier. Did you want to weigh in on this question we're still on?
Yes, I wanted to. I have my entire household on the same internet, so it's been.
That's what online meetings look like. Someone has to cut out.
Yes. So we're still weighing in on question 4, right?
That's correct. Yeah.
On mental health. Okay. Well, I think I hope I'm not repeating things that my colleagues have said earlier since I was disconnected. But for Ghana, I think local advocates have received training even from WHO to support those with mental health and psychosocial conditions. But I'm arguing actually today that we have not begun to scratch the surface when it comes to supporting persons with disability as a whole in general. Research has also shown an increase in mental health conditions, as you mentioned in your question. The question is that we are currently asking is, has it increased in the communities as a whole, particularly for those without this any form of diagnosis, right? So do we have new diagnosis of mental health conditions? As it increased in our higher education system as a whole, as it increased for our adults living precariously and children with disability as a whole. How do we know? How can we find out? And what do we need to, in order to support folks who are newly experiencing this, and those who due to COVID-19 have increased anxiety and other mental health conditions, and as it impacted them economically, mentally, physically, like we can go on and on. Here I'm talking more also again about financial supports, going back to the question on affordable and accessible housing and community mental health nurses and other disability professionals to support and mitigate all these determinants that we're seeing increases of. And so for me, those are the questions that, you know, are coming to me came to me when I was reading that questions earlier. That's how do we start to have this conversation of newly developed mental health conditions for folks who, because of isolations, this developed, and those who have increased, what do we do to support them to deal with it? And so that we can also eliminate the stigma that comes with it, because that conversation of mental health, psychosocial, and all these different disability labels are just compounding, and are we ready for that compound labels when it comes to impact of COVID and post-COVID?
Wonderful. Thank you, Evelyn. And it was a novel contribution, notwithstanding you having to miss out on the conversation. And it potentially closes off that question that I also joined with a conversation about long COVID. That might be all of our questions. I did want to give us a chance to answer some of the questions in the chat. But first, does anyone have any closing remarks? Anything we missed about this relationship between COVID-19 and disabled populations? Someone is making noise. I'm not sure who. So I'm going to ask Evelyn to contribute.
Okay, well, I think in regards to the long COVID and, oh, am I muted? Can you hear me?
No, no, you're not now. Just a bit of a,
oh, okay.
Yes, it's just delayed.
Okay. Okay. I think with the issue of the long COVID and how have preparations so far fallen short in meeting people who deal with COVID. For me, for social agencies looking at supporting disabled folks post-COVID on the continent in Ghana, I would say we need to rethink how we look at disability as a whole. Contextualize disability from a disablement perspective. And they should reach out to folks with both the lived experiences and the academic research background in critical disability studies and rehabilitation service studies as well, living and teaching in the global south. We need research funding. We need the pilot projects that the global north currently have, and and how do we culturally make it work, or can it work, or are we prescribing something that would not work? Like, I think there are so many things that we need to look at in terms of long COVID and post COVID.
Tech is cutting out on me a little bit. Is it my tech only? Okay. Evelyn, I'm sorry, you might be struggling. Unfortunately, I'm just going to ask Karen to mute you because it's making a weird disruption noise rather than your voice. But I do love a closing remark that is a call to action. Karen, do you mind? Do you know how to
we
mute?
need the programs. We need the education funding.
My apologies, Evelyn. But I do take from your technically fraught contribution that more work is needed to conduct trans-interdisciplinary collaborative research, given that like COVID has touched so many aspects of our lives. Any other closing remarks before I get to the Q&A portion? We're okay? All right, so my colleague in IDRR, Pierre Cote, is asking in the chat, so I just want to make sure we have a chance to address this question. The combination of unmet rehabilitation needs during the pandemic for people with disability and long-term conditions, and the new needs for rehabilitation due to long COVID are extremely alarming. So this dovetails nicely on our conversation to close. How can we effectively advocate to government to invest in rehabilitation services for those in need? Any takers?
This feels like a question I need to answer, and I know Pierre.
It's yours.
Yeah, and I'm not sure if I have the answer, because how to advocate, of course, would be building the case, and many, I mean, in terms of when talking to governments and ministries of health, because this is where rehab services usually are, at ministries of health, and how to influence policy is usually a game of stakeholders, and all have influences. And some policymaker may have different opinions and backgrounds, and so on and so on. So it depends on who you're talking to. I've written a scientific brief on the rehabilitation needs for people recovering from COVID-19. It's on the WHO website. So that's probably one of the tools you could use to advocate for rehabilitation services in terms of tools. Regarding the post-COVID-19 condition or long COVID, I agree it's alarming. I mean, knowing that up to 20% of people infected with the virus may develop post-COVID-19 condition, as in persistent symptoms beyond 3 months. And the majority are female, middle-aged. So we're looking at a large proportion of people that are economically active. So the return to work aspect is a huge issue and should be at least one of the components of your advocacy. I mean, rehab will improve the return to work in the post-COVID-19 condition population. And this is probably an argument that the governments will listen to. So the return to work and the economically active population that is affected. We already have issues, as mentioned by Heather and Tyler, on shortages of staff, whether these are in health services or in other. So I believe that would be one of the major arguments to use to advocate for rehabilitation.
Thank you so much. And Samantha has a hand up, and you might note in the chat that you're being praised for being as helpful as always.
I was going to respond by saying, like, if we're thinking about rehab broadly with as supports for folks with disabilities and folks who are managing long-term COVID, we can also think about often when supports or accommodations are put in place, they're perceived as like we're doing this on behalf of the person with the disability. But I like to flip that argument because I think it's effective, that in creating space for folks with disabilities to engage within the community, to be active within employment and all of the sectors that we've discussed, it also enriches the community. So in the same way that, like, there's a positive benefit for the person who identifies or who is identified as disabled, there's also a benefit to the folks who are engaging with that person, to the community, to the ability to, and we could have a different conversation about neoliberal constructs of success, but if we're including folks who are marginalized within our community, we're creating a stronger community, both for those individuals, but also reciprocally for the individuals who are engaging with them day to day.
Thank you so much, Samantha. And Evelyn, you cut out, unfortunately, midway through your contribution, but I think you were talking about long COVID, so maybe you have an ability to fashion your answer in response to Pierre's question in the chat.
What was the question in the chat?
That the question is, how can we effectively advocate to government to invest in rehabilitation services for people in need who have a long COVID diagnosis?
I think for us, or for Ghana, even understanding what long COVID means first is our first step to who has it and who doesn't, and how you know, the health institutional healthcare is supporting or is not supporting or should be supporting. So I think that for us is our first research, or our first way to look at and understand what long COVID or COVID in general means for this vulnerable population. But again, we live in, or Ghana, it's a country that when it comes to economic sustainability, it's very minimal. So when we talk about it, and then as I mentioned earlier, we are still looking at disability in Ghana as a charity case. So if we're going to do that, or if we're going to look at it from that lens, it's more of, you know, what I've been mentioning all day, funding, pilot projects. Folks like us want to sit on the monitoring and accountability table to make sure that we are using an anti-colonial lens to capture and report exactly what is happening on the ground when it comes to COVID, when it comes to long COVID, when it comes to post-COVID, however we look at it, when it comes to disability in general. I think, you know, we have reached a stage where research, where a lot of folks are qualified in disability justice, especially when it comes to Southern disability justice, living in Ghana, and we understand structural disabling issues affecting disabled folks. We are here to demand for changes, but also if we want to continue to look Southern disability justice as a charity case, at least let's create it and let's have a common, let's create it from a humanistic personhood approach and contextualize it, as I said, materialize it, and let's have more of a common goal with disabled folks in Ghana, prescribing their needs to the government, rather than us using prescriptions from the global north to mitigate what it is they need, or what does long COVID means to them. And this will then help to prescribe our healthcare need, especially when we speak of those living with long COVID, together with other disability labels. So it's complex. right, when we talk about this disability and impact, or when we talk about COVID and the impact on persons with disability, we still are looking for more research on it. How do we start to do that? This is where I think we need to start from to move forward and to start having more conversation and be able to answer more of these questions that we're asking today. So.
Thank you so much, Evelyn. And Heather, we have 3 minutes remaining. You might be our last contribution. Maybe.
I'll just make a very quick comment. Long COVID is challenging because we're in the early stages of being able to track and monitor and do research and provide results, which can help push forward our ability to advocate for resources for rehabilitation for this. So I'm wondering, and I'm sure people have been working on this, but going back and looking at other viral infections like SARS, we had the outbreak in Toronto in 2003, 2004, and other places around the world where there were long-term symptoms from those. And there is some overlap, in terms of this persistent fatigue and myalgia. I can certainly see some issues around avascular necrosis because of the large doses of steroids that have been administered to people with COVID. So I'm wondering if we can push some of that information forward to help advocate for the resources we need for rehabilitation in the interim while we're waiting for more fulsome research results from actually specifically to long COVID.
Wonderful. Thank you, Heather. Any other final remarks? Because she got in just under time. Wouter, you might be our
Very
closing
quickly,
statement.
yeah, we will be launching a rehabilitation guideline for post-COVID-19 conditions soon. And I guess of course, rehabilitation services in many countries are not prioritized, and maybe the pandemic could be used as a vector to advocate for rehab. In long COVID, it's probably the only health strategy. There's no symptomatic treatment for long COVID. Rehab will be the only strategy. So let's use the long COVID. I mean, this is not ethically right to say, but use long COVID as a vector to promote rehabilitation services may serve and benefit for more people in need of rehabilitation.
Thank you so much. I want to close us off by offering my sincerest thanks to our speakers for such a rich conversation this last 90 minutes. Thank you for those of us in attendance to bear witness. We're hoping with the consent of speakers that there will be a recording of this available for future viewing. And thanks again to Karen and others who are able to organize and hold the space for us. Keep us in mind for future joint panels. I believe this is a regular series. So potentially we will see you all in April. In the meantime, take care, everybody.
Thank you. Bye-bye.